Hi, I'm Professor Durka Dougall, Chair of the Health Creation Alliance. Thank you everyone for joining our spring event today, Health Creation for Now and Future Generations. We're delighted to be formally launching our manifesto, which is the product of conversation and inputs from so many members, contributors, stakeholders and others. And so it is great to see so many of you here today. In particular, thanks to our excellent speakers who will be sharing their insights and guiding discussions. And from me personally to Merron, our Chief Exec, and to our board, so Peter, Donna, Lynne, Brian, Neil, and with the help of Lee today as well. As you know, the Health Creation Alliance is the leading national cross-sector movement for systems change to reduce health inequalities through health creation. We launched our first manifesto 7 years ago, and we thought it was time, with all of your help, to refresh and update this, understanding that a lot has changed, but the essential elements of how to create health, and importantly, the need for health creation, has not changed. The question has not become about whether we need to focus on health creation. That's a given, we do. It's become about how to do this in practice, building on our tools and resources to get it right, for and with the communities that we are all part of and work for and with, getting practical, understanding that what we can all do can make health creation business as usual. Health Creation Alliance itself is therefore entering a new phase. As a movement, we want to work more closely with you to drive whole systems change so that health creation becomes business as usual. Throughout the next 12 months, we'll be publishing outputs linked to the manifesto, authored by engaged members, so do look out for them. Today's agenda has been constructed to help start, or maybe you've already helped to shape already, so in which case to continue our exploration about what's needed in practice with you, and to think through how we can each contribute and all work together to drive this even further forwards. So just a few housekeeping rules, and then we'll jump into the agenda proper. Please do use the chat function when you share your thoughts, opinions, and links and resources. We'll share the outputs, but not name names or attribute any comments to anyone. If you do want to share your contact details, please do indicate that in the chat as well. If you're not a member already, we will gladly sign you up as a member. So if you don't consent to that, please do say in the chat or the email that will be sent to you after today. Otherwise, we will look forward to working with you and updating you about events, activities, programmes, and really keeping up the dialogue and our work together. At the end of the event, there is a short evaluation questionnaire. Please do complete this. It will only take a minute or two, and we will really value your input. It will shape our continuous learning and improvement. And finally, it would be great to see as many of you as possible, so do keep your cameras on or the mics off until you speak. So with that said, without further ado, let me hand over to Merron, our Chief Exec, to talk us through the headlines of the manifesto. Merron.
Thank you, Durka. And I wonder if we could put the slides up. I've got a few slides to share with you just to take you through some of the key points from the manifesto, which was launched on Tuesday. So as Durka mentioned, my name is Merron Simpson, and I'm Chief Executive of the Health Creation Alliance. It's lovely to see so many people here, and I can see that health creation is now starting to catch on. After all these years of making the case, we know that the circumstances for some communities, for the workforce and society, are becoming very difficult, fairly dire now. But some systems are taking important steps towards health creation, and the mood music is definitely favourable. So if you go to the next slide, Durka's already mentioned that we published a manifesto in 2017. And this week, we've published our new manifesto, this time for whole system change. And a big thank you to everyone who's had an input. A lot's changed in 7 years, but there's still a big gap. There's a long way to go until health creation is embedded as business as usual across all ICSs, which is our ambition. We can't leave it to the politicians. We know that, although they do have a role. But through concerted action by many people across every system, we can make a health and social care system work well again for people and communities. And we have worked with our members and derived some actions to help guide you and we hope you find them useful, and also calls to actions for integrated care systems and all the organisations that make them up, and asks of a new government. So this is a surround sound manifesto. As Durka mentioned, the essential framework that we generated 7 years ago hasn't changed very much, but we've learned a lot in that time about how to apply it, how to reframe it for different sectors and situations, how to build on it, and how to drive change with the framework at the heart in different contexts. And it remains core to our approach. But today, I'm going to focus on some new insights rather than the framework. If you go to the next slide, we know that there are many drivers of health inequity. The causes are complex and multifactorial. But when you look through the community lens, which health creation demands you do, you largely see a common factor, and this is the social injustices that work against people, that hold them back, make life difficult, and that negatively impact on their health and well-being. There are, of course, cultural factors as well, which are different for different communities, but they are intensified by the injustices. So racial discrimination causes individuals within minoritized communities to rely on each other more often. And sometimes they can find bridging to other communities and services difficult. The injustices push people and communities apart. People lose confidence, they become isolated, and communities can become fragmented. So if we go to the next slide, our approach to health creation starts where people are at, recognizing that isolation that happens as a result of the injustice. It starts with, therefore, with connection, and it meets people at that point. Building meaningful and constructive relationships and connections helps to build confidence and helps people and communities to take control. Those are the 3 C's of health creation. And our framework contains the active ingredients for health creation, the 6 features of health creation: listening and responding, truth-telling, strength focus, self-organizing, reciprocity, and power shifting and sharing. And we've brought them together in this framework. And we use the framework, and it can help you as well to navigate the complexity of creating health in communities. It can be used as a standard or measure how health creating is your approach. And we use it with systems to redesign systems and services. And we've used it as well to inform the Core 20+5 national programme with NHS England. And if you want to find out more about the process of creating health, that's section 3 of the full manifesto. And we also have a video on this that we'll be making available very soon. So I'm not going to say any more about the health creation framework, but it is a core part of what we do. If you go to the next slide, we still have human rights, human social rights to good health. And the UK is one of 47 signatories to the European Social Charter, and indeed the European Convention of Human Rights. Now, the UK's accountability to those is lax, but they are still there. And one of them is for everyone in the UK has the right to benefit from any measures enabling him, her, or they to enjoy the highest possible standard of health attainable. What if all of us work together to create conditions for as many people as possible to access their social human right to health? We will soon be publishing a paper on this by one of our members, David Ainsley, who has done a lot of work on this, and we'll host a 1-hour lunchtime session with him. So please watch out for that coming through. And we also have some great examples in the manifesto document. So do have a look for those, and we will publish them as a standalone document shortly. So if we go to the next slide, this is about the fact that integrated care systems and bringing those sectors together through the integrated care partnerships in particular provides a really good opportunity to create a new ecosystem. But that has to be one where communities are partners in health, part of this health system that blends the formal and the informal, not separate from it. Requires power shifting and power sharing. It requires us as professionals to work as equal partners with us as communities. So let's think about that equal partnership. Investment in social and community infrastructure is also essential. It's high value things that often are run by communities, led by communities, and often relatively low cost. So why does this not happen more often? There has been disappointingly little progress on commissioning for health creation and for that community-led activity. So that's something that needs to be worked on. If we go to the next slide, we are absolutely convinced from the work we've done over the last 7 years that the framework and associated activity with that is a means of generating or driving whole system change from the ground up. We look through the community lens, and that makes a difference. Carlin is going to say a few words about that in a moment. But health is created in communities and at the front line between the communities and the workforce. And the whole system actually needs to reorient around what happens in the community to enable it and to create the conditions for it to grow. This is a big challenge. It is the big challenge for integrated care systems. But if you don't have the community in those integrated neighbourhood teams, if you like, or those integration teams at place system level, then you will not get the shift that we're all looking for. And that is something that I've become really convinced about over the last few years. So if we want to go to the next slide, this is really, this is the minimum really. If you want to work towards becoming a health creating system, then here's what you need to be doing. Just 6 things. I'm not going to go through them all, but you can see the framework comes into this again. And it's just a little bit of a sort of standard to work towards as you do this work. We all need a vision to see what good looks like. If you go to the next slide, coming towards the end now, the task for us all really is leadership. Leadership isn't about people at the top of organisations, it's about everyone, everywhere. And we'll hear more, I'm sure, from Durka and Bola Owalabi in the panel session on this. But to me, leadership means power shifting and power sharing and learning to work in a different environment where we're creating conditions for communities to create health. It requires some humility and perhaps a degree of unlearning as well. And actually, there are many barriers. Haven't really talked about the barriers, but there's a whole section on barriers in the manifesto. Communities have barriers. We know there are many system barriers, discrimination, national policy barriers. We all need to become barrier spotters and barrier removers, and that's now a significant part of the leadership challenge. So I'm going to leave you with the final picture just for 30 seconds or so, which brings all of that together. And this is, there's a number of elements to getting that whole system change. But if we have that framework at the core and the human rights in our minds at all times as something to work towards helping people to gain the best possible health attainable, then we won't go far wrong. And this is how we enable people to navigate their own access to health with support and treatment when they need it. Thank you very much, Durka. Pass back to you.
Thank you, Merron, for giving that overview and laying the foundation for the whole session that we're now going to delve into more. So without further ado, I think let's invite Chris for you to come in, please. So often the community perspective is left or not there, but actually we want to put it front and centre. So Chris Carlin, Transformation Manager for NHS Cheshire and Merseyside, who's going to tell us about the community perspective, speaking from his lived experience and why it makes all the difference. Chris.
Thank you, Durka. Yeah, so I'm a transformation manager for the NHS, which is no easy task. It definitely needs transforming. But just to give you a little bit of my background, because why should an NHS person speak for the community? The community is very good at speaking for itself. I wasn't always an NHS person, so I spent 20 years working in the voluntary sector in one of the most deprived boroughs in the country. Came from a very humble background, never went to university, so I find myself in quite a privileged position, far further than I ever thought I would be. And I'm determined to use that for the greater good. So that's just a little bit about me, just to give you some context. But really, what I wanted to talk about today is the disconnect between the two worlds that I understand. So like I just said, I understand what it's like to live in poverty. I understand what it's like to work in the voluntary sector. And now I understand what it's like to try and transform the NHS in my own small way. And what I really, really see is the disconnect. So I have a foot in both worlds. I understand both. And I find it, or have found it previously, incredibly hard to reconcile these two worlds. So the voluntary sector is full of passion and inspiration and virtue, and it's organic, and it's an ecosystem, and it's a living entity. And then the NHS is a systematic think tank, problem solving, quantifiable. Can we count it? Can we change the numbers? Both are full of fantastically wonderful people who want to make change. But actually, where the rubber meets the road, there's this massive disconnect. So my real joy actually of being involved with the Health Creation Alliance for the last couple of years is I think this just could be the Rosetta Stone, right? This just could be the thing that makes these two languages translatable. Both are equally valid. Nobody's the bad guy in this tale. But and just in case anyone doesn't know what the Rosetta Stone is, I'm sure you're all far more educated than me. But basically, it was a stone that was found that had hieroglyphics, ancient Egyptian language on one side, and a form of Greek on the other. And before that stone was found, and it was only in about 1900 or something, nobody could read hieroglyphics at all. There was no way to crack the code. And what the Rosetta Stone did was give us a language that we understood that actually could be translated. So that may or may not resonate with you or not, but certainly in my position, when I can see these two wonderful things that don't speak the same language. And I think what our manifesto gives us is a real tangible way to actually start to translate. And even I've been thinking about this a lot because I've actually changed what I was going to say today because the Rosetta Stone thing came up in another meeting we were in, and we thought that kind of works, doesn't it? So I started to think, well, what's the Rosetta Stone in this story, if that's the right thing? Is it the manifesto? Well, that's part of it. Is it the framework? Well, that's part of it. But you know what really is the Rosetta Stone? It's you guys, it's the people that can carry this message, that can carry these values, that can take them into meetings and say, you know what, there's a better way. Because ultimately, we all want the same thing. 80% of ill health has nothing to do with doctors, with GPs, with hospitals. You know, Lord Crisp, Nigel will speak later, and his book, you know, Health is Made at Home and Hospitals for Repairs, absolutely bob on, absolutely bob on. And I'd take it further, actually. Health's created not just at home, health's created in the street, health's created at the Veterans Club, health's created, you know, in community. So if I say one thing today, it would be the Rosetta Stone, understand this stuff, take it, translate it, and just keep pushing, because I think there really is something here that could be the missing piece. And I think I'll probably leave it there for now, unless you want me to carry on, because I could talk about this stuff forever.
And I could listen far longer, because that is fantastic. I could not have put it more beautifully myself. And I think that is the challenge we're dealing with, isn't it? So let's all hold on to that. And Chris, we might need to come back to you, not only now, but going forwards, because it's exactly that we need to face, isn't it? And look in the chat, you'll see how many people have reacted saying they agree. Okay, so now, with that amazing start, let's show you a video from Professor Mark Gamsu, who's from the School of Health and Community Studies from Leeds Beckett University, Institute for Health and Wellbeing. Many of us know him well, and he's done some really interesting work in terms of the integrated care systems. So asking the question, should integrated care systems mainstream health inequity?
Hi there, my name's Mark Gamsu, and I'm one of the things I do is I'm a professor at Leeds Beckett University, and I'm going to talk to you about a piece of work that I did in that capacity. I'd first like to thank the Health Creation Alliance for inviting me to speak. I'm afraid I can't make it. I'm on a holiday with my family. If people would like to continue the discussion, please get in touch with me either through my blog, Local Democracy and Health, or on Twitter @MarkGamsu. I would just say the title of the blog really sort of says what I'm about. I'm interested in how we as citizens, as communities, as people involved in community organisations and others can influence local health systems, particularly with regard to health inequalities. Inequalities, I'm not going to run through a great deal of detail on that. All I'd say is I think it is, there's a lot of good material that's come out in the last year or so. Joseph Rowntree Foundation, Institute for Health Equity, the King's Fund, BMA, among others, and in particular many of them have flagged up their concerns around the continued growth with regard to inequalities, and in particular the impact of the social determinants of health, financial insecurity, poor housing and so forth, and the impact that has on people's health. And indeed a number have cited also talked about the impact that then has on the NHS, which is of course the case either in terms of increased demand or in some cases inappropriate demand or indeed underutilisation of some services. The important area, though, for me, is about the impact that the NHS can have on addressing health inequalities. And NHS England talks about three areas: the role of the NHS organisations as economic anchors, which is fine. However, that's not what the NHS is there for, to address health inequalities through the economy. Secondly, its leadership role with regard to integrated care systems and working with others, which does connect the NHS potentially more with the social determinants of health. And thirdly, through focusing on access and to its services and the quality and relevance of those services to people experiencing inequalities. One of the things which is a real positive, and Bola is speaking to you later, is been the £200 million that NHS England has made available, initially ring-fenced in year one, to address health inequalities, that funding being made available to the 42 integrated care boards. £200 million, it's an important bit of public money. It's tiny compared to the total budget of the NHS in England, which I think is around about 180 billion. In Sheffield, that means where I live, we get about £2 to £3 billion a year specifically for addressing health inequalities. So one of the things we learned from this piece of research that we did, funded by the NHS Confederation, was where we interviewed 20 of the 42 integrated care board health inequalities leads. What we learned was many saw this as catalytic funding to influence the huge amount of money that goes into NHS services every year. And that was the strategy that a number of them quite clearly articulated, rather than using it to directly address health inequalities themselves. One of the things that emerged for us most importantly was the role of leadership within integrated care boards. And an example of that, given its importance, is to paraphrase one of our interviewees who said, we get phone calls from NHS England for compulsory phone calls when they want to talk to us about our performance on financial balance, or they want to talk about our performance on waiting times. We never get phoned up saying, why are you doing so poorly on addressing health inequalities? So that means the responsibility for actually responding to this rests with leaders within integrated care boards. And we did find examples of that. However, there were plenty of cases where, at best, I would say the leadership was unclear. One of the ways to look at that is through the joint forward plans that integrated care boards are required to produce. And we again found most were unclear, put it politely, about what they were doing with regard to inequalities, although they often mentioned the health inequalities words lots of times. There were some really excellent examples, though. One of the ones that stood out for me was North East London. Every area of their responsibility that they so, for example, urgent and emergency care has a section on health inequalities. So, for example, with regard to urgent and emergency care, they talked there about how will this transformation programme reduce inequalities in North East London. And they talked about increasing quality of access across the geography, ambulance flow workstream management, support to patients with learning disabilities and autism, and so forth. So if you are interested as a citizen and you are unlikely to talk to the leader, the chief exec of the Integrated Care Board on a regular basis, you can go to the North East London plan and find out what they're doing. And you can either support it, join it, or disagree with it, because you can see quite clearly what they're proposing to do. And I think going forward, we should be expecting each integrated care board to be spelling out across all system areas, just as North East London have done, what they're proposing to do and the action they're taking forward. And the final thing I'm going to say is I think we should also be expecting integrated care boards, as to some degree is happening where I live in Sheffield, to be investing in institutions and organisations that are going to be around long after integrated care boards have disappeared. And by that, I mean expectations not just on NHS organisations and local government, but in particular on the voluntary and community sector, who are working alongside communities experiencing health inequalities. I'm going to have to stop there. My time is up. Please get in touch, and I hope you have a good day. Thank you.
So let's move into the panel conversation, so I'm going to invite colleagues to join me. So we've got 4 fantastic colleagues. So Professor Bola Owalabi, who is a dear colleague over years, but is the director of the National Healthcare Inequalities Improvement Programme from NHS England. We've got Lynne Ridsdale, who's the Chief Exec of Bury Council and Place-Based Lead for Health and Care NHS GM Bury. We've got Dusty Thomas, who is Morecombe Poverty Truth Commission, who's working with the Poverty Truth Commission, and also community activist. He's got lived experience, and he's actually very actively involved in the Let's Be Friends charity, working with people who are street homeless, sofa surfers, and those at risk of homelessness, and also chairing organisations, including working with ICB, so Integrated Care Boards. And then we've got our own Donna McLaughlin, who is our fantastic non-exec director from the Health Creation Alliance, and until recently, the director of social value creation at the Northern Care Alliance. So what we'll do is we'll ask each of our colleagues to take 3 to 4 minutes in turn to answer the question, do we have a clear line of sight to health creating systems and communities? And then we will have a bit of a discussion between us, informed by your chat. So if you've got questions, please put them in the chat as well. But let me hand over to you, Bola, and thank you for joining us today.
Thank you so much, Durka. I hope you can all hear me. Thank you for the invitation to be with you today. And it's been great working with you, Durka, in your previous role and your current one with the Health Creation Alliance and with Merron and the team. And just to say, first of all, congratulations on the manifesto document. It's a really powerful document, and I hope that we can collectively work to make sure that it translates into action for people. So it's good to be here. I think in response to your question about do we have a clear line of sight, I would say absolutely. And I will set out the reasons why I'm saying that. Certainly, from a health inequalities point of view, as you've rightly said, Durka, the 4 aims of integrated care systems, the reason they were set up: to improve the population's health, to tackle inequalities in access, experience, and outcomes, to drive social value contribution of the NHS, and value for money. So to that extent, I would say it couldn't be clearer in the fact that when the ICSs were set up, 4 aims were defined. Secondly, the NHS Constitution itself talks about ensuring that is access to care for all. Thirdly, the NHS long-term plan set out that we will accelerate action to address health inequalities. And finally, in every planning guidance that the NHS has published since 2021, we've set out clearly strategic actions for addressing health inequalities. I also recorded a podcast in which I set out the roles of the NHS in tackling health inequalities, first of all, as a commissioner and provider of services. And therefore, it is powerful in using that leverage to really benefit seldom heard communities. Secondly, the role of the NHS as a key partner within the integrated care system, working with our local authorities colleagues, working with our voluntary sector partners, working with people and communities to address those big social determinants that drive health inequalities. The role of the NHS as an anchor institution, so that when we make decisions about how we employ people, how we buy things, our procurement, how we use our estates, that we leverage that role as an anchor institution to help the seldom heard. And finally, the role of the NHS as an employer. 1.4 million people work in the NHS. And if we address their health inequalities, then we gain the credibility to address health inequalities in the wider population. So I think we have a clear line of sight. And the other thing we've done is to set out a clear vision that what we're trying to achieve is exceptional quality healthcare for all by ensuring equitable access, excellent experience, and optimal outcomes. However, despite that clarity of direction, the issue is how do we translate the legislation and the policy into meaningful, tangible actions with demonstrable, measurable impact in people's lives. For me, it's how we translate all of those things in a way that it makes sense to my patients in Cresswell, in a way that it makes sense to Andrew, the homeless man that I met on Clacton-on-Sea Beach, and people like him up and down this country. What does all of that mean? And I think from an NHS point of view, it means a number of things. Leadership, courageous leadership, to make sure that the funding that has been made available to address health inequalities is spent for those marginalized people and communities for whom it was intended. And for those who haven't read Mark Gamsu's report, Putting Your Money Where Your Mouth Is, I encourage you to please look at it, because that's exactly what he's getting at. I think it's about implementing the 5 strategic priorities that we've set out, that as we come out of this pandemic, restore our NHS services inclusively, mitigate against digital exclusion, make sure that our data sets are timely and complete, embed the Core 20+5 approach, and finally, strengthen leadership and accountability, because without that, we'll just be a talking shop. We'll have lots of policies, we'll have lots of legislations, and people's lot will not be better as a result of all of that. So that's my view. We do have clarity of direction, but we need courageous leadership to make it real in people's lives. Thanks, Durka.
Amazing, thank you. Let me move to Lynne. Let's come to you to get your thoughts.
Brilliant. And I've just scribbled down courageous leadership because I completely agree with all of that. And I think courage is what it's about. Because in the face of some really severe socioeconomic headwinds, which I think are worsening health and worsening the ability of the system to do what it believes are the right things, it takes courage. And I think my big message is we know what to do, but we've got to keep doing it. So I say all of that as somebody that comes to speak to you from Greater Manchester. We are big believers in health creation, always have been. And this, of course, was at the heart of our devolution deal, which was one of the first back in 2016. That was all around population health, embracing wider determinants, a really powerful role for the voluntary and community sector, and the integration of health and care services across the sectors. And guess what? It worked. I don't know if people have seen, but there was an evaluation piece done about 3 months ago that showed that there were improvements across a whole basket of health outcomes during that period of time, both self-reported and life expectancy, and improvements in healthy life expectancy. So the model was proven, was enshrined then in the ICS framework, so we welcomed that, but are already finding that the ICS model is not as effective as the local devolution one was, which would on the face of it be a surprise, but actually when you look at it, it's probably because even though it was based on best practice, it's a national model. It squeezed some of the flexibility out. Have we really got the benefits of subsidiarity that we had when it was Devo was on a regional basis? Probably not. It does now feel that we're in a bigger system. We've got regulators to please, different regulators. The references then to the NHS constitutional standards designed to drive excellence, but actually it's a bit of a straitjacket because they have to be met. There's a lot of governance around all of this. So at the moment, we're not where we want to be, even though the ingredients are still arguably the right ones. And I think it's also important that as well as the system design here, there is something to think around about the capacity of communities to engage in the conditions we're trying to set as well. There is no question that the complexities that we've seen post-COVID are blowing us all off course. The volume of demand, the complexity of demand, the challenges in children's health as well as adults. It's not just the older age demographic we've got to deal with, it's the younger kids, it's the complexity that those children are now facing, which will take years to work through. And the economic stuff, there's a number of people who on this call who can speak for themselves from the VCSE sector, but we're certainly finding the capacity in that sector is really stretched. The demand on you guys is just as big, and your capacity and ability to stand up volunteers to support is really diminished at the moment because everybody's under the cosh. So it's tough, isn't it? I think though we're still trying. Up in GM, we are relentless with our ongoing evolution of the operating model for the ICB, which is all around integrated commissioning, community commissioner, community model, the absolute role of lived experience and service user and patient voice. And locally, we're trying to underpin that, certainly in Bury. My favourite thing about my job is the strategy we've developed. Merron was part of the journey early doors when we created our community strategy, which we've named Let's Do It. And Let's being an acronym for basically a new way of working with the community, local enterprise, working together, strengths-based, and really trying to reinforce the way we want our staff to work, but also participation from the community. And I think one of the things that really excites me around this manifesto is just mainstreaming everyone's a leader. This needs to come together with a role from everybody. It needs to be bottom up. It needs to be inclusive leadership and absolutely courageous leadership. So yes, we have the line of sight, but let's not kid ourselves. This is we have an evidence base to support it, but we've got some very real practical strains around us that are, I think, impairing our ability to deliver.
Lovely, thank you. And I'm seeing a connection here because Dusty's just put that he used to live on East Street, and I'm looking at Donna who's coming next. This wasn't intentional. Dusty, let's come to you. What do you want to say by way of introduction and ask the question? Oh, and we might have you on mute, so don't want to miss anything you say. So
rookie error, but I think I was still muted from the beginning. I was obviously I try to get as much involvement from the lived experience voice through to health organisations that I'm working closely with to get the VCFSE sector's voice heard as well, because as was previously mentioned by Lynne, we are under a terrible strain, and more is expected of us, especially around health outcomes, with very little funding. And it's that funding. I mean, I'm part of the Lancaster District Health and Wellbeing Partnership Board. We've just got our budget that we normally allocate to VCFSE sector, and it's a seventh of what it used to be last year. So I know our ICB is struggling as well. So it's there's a lot of community organisations and community voices that are happy to feed in, and we're working more with targeted areas, which is high deprivation areas. You might have heard Andy Knox mention before that you can walk 2.5 miles up Morecombe Prom, and the life expectancy differs by 15 years. So, yeah, we do have some high deprivation areas, but I'm glad that we're starting to work more on those high deprivation areas in the health. I was really impressed with the manifesto. It speaks to a lot of what the heart of needs to be changed, but it's like trying to turn a massive big oil tanker with the NHS, and you don't know who you're working with. Sometimes, I don't know whether I need to contact University Hospitals in Morecombe Bay, whether I would need to work with Lancashire and South Cumbria Foundation Trust, whether I need to be, dealing with the ICB. It's become a very overcomplicated system, and you need to bind all those together, I think, to make sure that that one, people's voices are heard, but two, it seems too fractured as a health system, whereas they're not all working totally in tandem. And I'll also plug at the moment, while I'm on, Andy Knox has just written a book called Sick Society. I don't know if I know Durka knows him, which covers everything from health to climate change. But a lot of what he's put in that book does actually relate to manifesto as well. So, there's a lot of people wanting to work right and make sure everybody gets heard, and make sure that, our joint strategies as a whole. So I'd love to see where we go from here. So, yeah, I'll finish there.
Lovely, thank you. And yes, Andy's book is great. So basically, Donna, let me come to you to get your thoughts, and then there's questions coming into the chat, and I'm going to post probably the one from Mark Gamsu's work first, if that's all right. It's a bit mean, but the biggest barrier that he seemed to have spotted. But Donna.
Thank you, Durka. So my name's Donna, and I'm privileged of being part of the Health Creation team, but until recently was Director of Social Value for the Northern Care Alliance. So again, a bit of a GM flavour to this panel today. But I think what in the video that we'll share later, one of the things that Mark talks about, which really resonated with me, is that I had board responsibility for performance, and I would often get a call from regulators about operational performance, about finance, about metrics, but very rarely get a call about, are we a good neighbour as a hospital? What are we doing around our wider community and our economic infrastructures, which, as Chris referenced, is about 80% of what drives healthier lives. But for me, a hospital's always been part of the community. Although there is a tendency to look up and to regulators rather than out to our communities, what I, through my role as Director of Social Value, try to get an acute organisation to think about is what is its role in as a community and an anchor organisation. But how do you land that within an acute hospital? And Lynne spoke about the strain that is on the system currently that colleagues have talked about. So let's think about this within what's happening within treatment regimes within hospitals. So there's a growing trend towards precision or personalised medicine, which a lot of the fancy new drugs in the market now actually take into account individual genes, environments, lifestyle, and target, for example, within cancer, those specific cells rather than traditional blast of chemotherapy that it could destroy healthy cells along the way. So for me, if you take that analogy. It's not as good as Chris's with the Rosetta Stone, but bear with me. If hospitals think about the treatment being more personalised and more precise, then actually as an institution, as organisations, we need to think about that wider environment, the lifestyles and the wider factors in which we operate. So we've got to do more than just the brilliant work of the giving of the pills. We need to think about our role as anchor institutions. So Bola talked about hospitals fulfilling their role as an anchor institution. For me, that is about who do you employ? And so how do we outreach into our communities and think about the assets within those communities rather than think about we've got a workforce shortage and how can you help us? It's about thinking about what are the skills within that communities and how we can use those. And there's some examples in the manifesto around a project in Oldham. Orla's on the call and there's some brilliant work that she's doing in Salford around thinking about how do we use the spend of anchor institutions to support young people to become entrepreneurships, and also there's about how do we use our land and buildings. So hospitals can't just get bigger and bigger. For every health problem, there isn't a service solution. So just when Lynne was talking then, thinking about some of our constitutional standards and waiting lists. So waiting lists are quite rightly consuming a lot of attention and thought within acute settings. But is our solution to keeping people well while waiting, setting up more and more pre-op clinics? Or what if we took a health creative approach and asked people to self-organise and support each other, rather than seeing that there is a service to approach that? What if we saw hospital canteens as community cafes, a place to provide cheap hot food and a place to meet, a place for human connections to reduce isolation? So if you were to take a library, for an example, are libraries a book storage facility, or is it a place of learning, a job club, a knit and natter, a community hub, and increasingly in some rural communities, a banking facility? So are hospitals buildings for sick people, or do they have the potential to be the focus points for social justice? And I would just reflect on what Bola started with. This is within our constitution. This is what the NHS was set up to do, and it says, I'm just going to find the notes. The NHS has a duty to each and every individual that it must respect their human rights. At the same time, it has a wider social duty to promote equality through the services it provides and to pay particular attention to group or societies where improvements in health and life expectancy are not keeping with the rest of the population. I think that's all I want to say at this point. Back to you, Durka.
Perfect, thank you. And I know, Bola, we're losing you at 2, so I'm going to come back to you for input first, though, or to kind of think through what you might want to share with us before then. But thank you, really rich discussions, loads of questions. There's a theme coming up in the questions about, and Merron, I think you started it off, which is how should ICSs mainstream health inequalities? I think we'd probably all say yes. But in practice, how? And so there's also some inputs from Andrew, which seems to concur with what Mark's work found. So back to Mark Gamsu's work. He obviously found things like leadership, structure, relationships, catalytic funding were all kind of major things that could help. But it's interesting that he found that the biggest barrier was possibly the disconnect. So back to your word, Chris, in terms of the ICB priorities and maybe the national priorities, maybe operating plan, maybe political, maybe otherwise, which tend to be much more short-term focus. Is that right? And any comments about that, colleagues? And then Bola, in particular, children and young people, there was a question about what could be done. And I know your core 20+5 work, you did a dedicated piece on children and young people. So I don't know if you wanted to come in on that. But yeah, over to whoever. And I think, Bola, you've unmuted, so I'll come to you.
Thank you, Durka. And I just want to say thank you so much to my co-panelists for, their really important comments that is advancing the conversation still further. And Donna, explicitly reading out the section of the Constitution in the way that you've done. Thank you so much, so that we're all in no doubt about the fact that it does say that. So thank you. I think a couple of things in terms of the disconnect. I'm not sure necessarily that it's a disconnect. And the reason I say that is when you look at the ICSs, there is a report that I've put in the chat box, which is from the NHS Confederation. And what they did was they did a deep dive into all the 42 ICSs. Sorry, it was the South, West and Central CSU, to look at what have they said about health inequalities in their 5-year strategies. What have they said about health inequalities in their joint forward plans? And they found that every one of the 42 ICSs did reflect the strategic priorities that we've set out nationally. It wasn't missing, it was there. But it's what I was saying earlier on. We have to translate strategic intent into actual action on the ground. So the disconnect I see is in translation. And that is why I go back to Mark's work, which is very clearly saying, in order to do the translation, you've got to put the resources behind the strategic intent. And in the midst of the competing priorities, as Lynne has just rightly said, against those headwinds, that is where courageous leadership becomes incredibly important, to hold our nerve and say, this is what the resource was intended for, and we're going to use it for those people and those communities that are marginalized. That takes a lot of courage when you're battling headwinds. And I think in terms of children and young people, I just want to absolutely agree that whatever we do, there must not be an addendum or an afterthought. Because if you look at the Health Foundation's report, Health Inequalities by 2040, it's going to cost us so dear as a country if we don't address health inequalities, not just in the adult population, but actually in our children and young people. And that's the reason why the Core 20+5 approach for children and young people exists. Again, we need to resource it to make it real on the ground. Thank you.
Thank you. Lynne, shall I come to you? So there's a question specifically about how you're capturing and showcasing the impact of the work that you made. But I mean, any comments on the other things as well, and other speakers' inputs? Absolutely. Mike, to you.
Thank you. And I'm just mumming over Bola's comments there, because I completely agree. And as you've heard, I really welcome the challenge of courageous leadership. But I think it's just important to reflect on how very difficult that is with the resources that we have, the stretch on NHS and social care services, and the reality that, we are in serious deficit. And certainly from a Greater Manchester point of view now, we are now well within the NHS intervention journey, because both our performance and our financial spend are so out of line, because we are sinking underneath the scale and relentless march of demand, which is because of poor community health, and that's why we have an operating model that says we've got to fix that. We need to drive population health improvements. But at the same time, we absolutely have cuts on the table, which are coming straight out of population health, because when you're under the cosh, the first thing you do is cut prevention. And we all know it's all wrong, but we are not even in a place where there is courageous leadership as an option to us. It's a zero-sum game. We can't balance. We have to sustain statutory services first. So I think there's a real moment of peril for the system here, because we must do what's right when we can. But when with the pressures that we are all facing, that isn't even on the table. But that said, demonstrating progress, and I welcome the challenge, because I think that's right. How do we build the confidence? Well, we need to evidence it, don't we? And the way that we are trying to do that is through a combination of feeding beasts as far as we can with performance measures that show what we're doing and the impact it's having. But also these days, there's a recognition that people connect through relationships and through stories. So we're also trying to make it very real, very human, create opportunities for people to come together, exchange those stories, build the confidence when they see the change that we're making. So some of the stuff that we're reporting, just looking whilst people were speaking on our last performance stats, and some of the things that we're playing back now, particularly around intermediate care, turnarounds out of hospital, the number of people now using our services, the number of rapid response referrals, the specialist services that we're standing up around things like emergency falls, everything we can do to keep people away from the hospital front door, and just how much business effectively we're turning around, but what that improvement is looking like. I'm just looking, 6,500 people in our rapid response system every month. We're the busiest in GM now. That we're tracking when we're measuring community engagement, we're tracking that and actually monitoring it. And apparently, don't ask me how we're tracking it, but I know that we used to ask 57% of people about our services, how they wanted to work with us, what they wanted to achieve. So half of our contacts got to actually ask what they wanted. We're now up to 87%. Thank you, much more like it. So we can actually measure the extent to which we are meaningfully co-producing care and reflecting aspirations. But also some of the really powerful stuff, and going back to the work that Merron did with us, I think it's important to give her a shout, because the wider determinants coming through and just showing how we can make a difference by some of the very practical stuff that my sector does in local government. And we work with Merron on our housing strategy and really trying to create more specialist housing that prevents people from needing to live in expensive resi care that can often be the last place they'd want to live and keep them away from hospital. And we've done a huge amount to invest in new units and build new specialist provision to allow people to live independently. And we've shot up the leaderboard from being pretty much the most rubbish in GM to one of the best. And my favourite story is 40 people with learning disabilities that had to live outside of the borough because we had nowhere for them to live, have now come back home. Now, isn't that beautiful? That's 40 people and their families' lives turned around because we've created the right place for them to live and to live a valuable independent life. So I think it's across everything. It's track the stuff the Constitution wants us to measure, weigh the proverbial pig, that is important. But also it is people, it's communities, and it's storytelling.
Amazing. And in that story, just how powerful, and it's in the chat as well in terms of that notion of storytelling. So thank you. Okay, Dusty, let me come to you if that's all right, and then I'll come to Donna, because there's a couple of comments in the chat. Donna, it was about the kind of innovative thinking, the kind of lateral thinking that you were outlining some of your examples. It got people excited, and there's examples being shared in the chat. So it's almost, how do you create the space, the conditions to do that, to really get this right? But Dusty, let me ask you first, if that's okay. So in your work with ICBs, as somebody with lived experience doing all the great things that you do, what is it that you feel really enables you to be included? How do the ICBs kind of create the conditions where your input can really make a difference?
Well, because I've been working in the VCFSE sector for the last 16 years, I tend to elbow my way into places where I'm not always welcome and make sure I speak my mind, but that's not always available for people. So, for example, with the Poverty Truth Commission, we have what we call community commissioners and civic commissioners. So the community commissioners are the people with lived experience. We often work with them for 4 months before we even start the next round of the commission. One, they pick the civic commissioners, whether it be GPs, whether it be directors of public health, or whether it be from our local council or whichever department they want to work with. But we often work with them for about 4 months, as I say, one, to get their resentment away from a little bit so that we don't end up in shouting matches, so that we can have proper discussions and debates, but also to build their confidence up so that they feel free to speak as an equal, talking truth to power. And I think that's what it's all about. Fortunately, as I say, we had the Health and Wellbeing Partnership yesterday. We had one of the Residents Association leaders from one of our target communities that has a lot of lived experience herself and did a great presentation. But yeah, it's giving people the confidence that their voice will be heard, but not just heard, that it will be acted upon. And unfortunately, for a lot of people with lived experience, they've told their stories before, they've, thought, yeah, it's gone in one ear and out of the other, and not been happening. So, I mean, one of the things we did in the first round of the Poverty Truth Commission, out of our health team, we developed what was called a citizens rep, and that person's sat with the Citizens Advice Bureau, but rather than people getting re-traumatised, telling their story time and time again, whether it be with health, whether it be with the DWP, whether it be with the City Council, that citizens rep will speak for them. So they're not getting re-traumatised all the time. They've worked with them for a couple of months, they've got their full story, and then they're able to present that to the various different departments that people are keep getting re-traumatised with. And you've got to realise a lot of the stuff is that people have to go over and over and over is very triggering for them sometimes. So it's all about, you know, doing that in a gentle fashion and making sure it's like a you said we did sort of event, rather than I know a lot of people probably on this call as well are what we call fixers. So they want to hear a problem and they want to find a solution to it. But the motto of Poverty Truth Commissions is nothing about us without us is for us. And that actually came from the anti-apartheid movement in South Africa, but it's been adopted by all the Poverty Truth Commissions. And it's rather than doing to people, it's working with those people.
Amazing. Thank you. And what wise words for all of us to heed in terms of that repeated storytelling. Bola, we're at 2 minutes past 2, so we've already taken up a bit more of your time than you can have been committed to, so thank you. Shall I just quickly hand back to you, just for any final words from us, just to say a huge thank you for joining us. Really appreciate it.
Thank you so much, Durka, and thanks again for the invitation. And I'm really sorry to need to drop off. I suppose I'll leave with a parting thought that we don't need to shoulder this burden on our own. Our communities helped us during the pandemic powerfully. They mobilized resources that we didn't even realize existed, and not always in terms of the money. I would ask us to remember that and to see them as our co-partners in this endeavor and go forward on that basis. Thank you.
Amazing. Thank you.
Bye for now.
See you again soon. Thank you. Totally, truly powerful and absolutely spot on. We've got still another few minutes for this part of the panel discussion. So Donna, there is a real interest in terms of how do you create the conditions for lateral thinking and for maybe joining things across sectors for health creation in the way that you were beginning to outline, for example, your cafe example?
So I think there's a few things, just to pick up on a few things that come through from the chat. I think the first thing is around establishing trusting relationships that go beyond a pilot. Because I think what we're really good at doing is we'll do a pilot and then we'll say we need more money. So so the approach within the NCA was there wasn't a department for social value. I argued that we buy stuff and we employ people every day and we have buildings that we use every day. So see that as your resource, not I need a separate funding in order to do this, because otherwise you're just going from one pilot to the next pilot. So so we think about some of the employability programs is also to recognise that we, the NHS, aren't good at all of this, that there are other partners who are better, and not to have that almost NHS arrogance that we can do it. Actually, we can't. So actually community development, in reach into communities, there are other people who have much better skills at that. And it is about developing those trusting relationships to enable that to happen. So there was a question about young people. One of the programs we did was worked with a youth charity. So they knew the young people, they could reach them. They had better networks into young people. So they worked with the young people initially, and then we went out to the young people and then gave them work experience, employability skills, and guaranteed interview. And that was explicitly in terms of if we'd gone out and said, do you want a job? they'd have gone, well, who are you? Whereas actually that youth-based organisation had better connections. Similarly, we've got a programme that works in Oldham, and the employability programme runs from the mosque. And the mosque is 200 to 300 metres from the edge of the hospital. But rather than expecting people to come to the hospital, you go to the community, because actually that was one of the things that we were quite rightly criticised for, is that you never go out to the communities, you expect the communities to come to you. Now, that is all doable within your mainstream NHS funding, because we have recruitment teams, and we have, at the minute, we spend money on getting people into jobs. So it is about thinking about what is the resource that you've currently got and how we could use that in this with this approach. So I think for me, it's that humility, that you don't do it on your own, you do it in partnership, and in true partnership, which is you recognise which is the bit, what you know, I often said, what does the NHS bring to that party? It brings jobs, the connections into communities, and employability. There are other people who are in communities who do that better. And then I think the other bit around impact is measure some of this. So a really crude one is, we measured who we employed who were local, who we employed who lived in the areas of deprivation, and we use that to track our progress, because that's a way of saying is, if you're trying to look at poverty, well, if you can lock more of your salaries into local communities, that is a way of using your social economic power to invest in communities. I don't know if that answers the question, Durka.
Yeah, absolutely. So shall we now do a quick run round in terms of final thoughts and messages. So shall I start with, should we go Lynne, and then I'm going to go back to Donna, and then Dusty, because it'll be nice to land with actually some of your thoughts in terms of lived experience. And yeah, some of the stuff that you said, there's some really powerful comments to it in the chat, wanting more. So Lynne, Donna, and then Dusty. Any final remarks, thoughts that you kind of go, actually, these are the key bits now that we've had this discussion?
I think the key bit from me is how we turn this into a movement. It's how do we get behind this manifesto collectively to really make some noise, push the agenda, and get more traction. I think in the context of the gloomy remarks I make as a good old-fashioned bureaucrat in the middle of an ICB that's in a bad place financially, but yet meeting all of you who are hugely enlightened, whom I fully agree with, and who devolution points to the evidence that this conversation is the right one. How do we keep it going? How do we sustain this confidence and make stronger representations collectively that the system has to change to work in this way and to put health creation at the heart of what we do, rather than when we can afford to, and when there is some headspace.
Lovely, thank you. Donna.
I think if we're mainstreaming this, we need to use this approach for what we're trying to what our current problems are, and not see this as an addition. This is a means of supporting the day-to-day activity of what we're trying to do. It isn't, it's not an addition to. It is a means of, if that makes sense. So I think that would be my conclusion.
Lovely, thank you. Dusty.
So, yeah, one of the things of my pet hates is duplication. So I would also always check before you have your right ideas, we'll do this, we'll do that, we'll do the other, that you check that it's not already happening within the VCFSE sector, and use the expertise of those people to deliver things for you. And yeah, we're definitely trying more in this area to make sure that all the anchor institutions, not just health, not just the county council or city council, whoever are anchor organisations, do start working together rather than separately. If we don't do joined up working across all boards, then we won't find good solutions.
Amazing, thank you. And I guess for me, so thank you, colleagues, for your rich, invaluable inputs and for that beautiful discussion. I guess the key message I'm taking away maybe from the sessions that we've already had is we're on the right track. The manifesto is actually a massive opportunity to really go even further. But that's going to take each of us, so not somebody else, but each and every one of us to look at it again and go, what can we do? And as Merron has said in the chat, hopefully the Alliance is a convening force. It's a social movement that if you're not joined into already, do become a member and join us. But it's across us all that together we can, and how powerful and how exciting to think about what's possible. So thank you. Thank you for our panel one. So Lynne, Dusty, Donna, Bola. And we're now going to move into the next session, which is going to be a deep dive into social care. So I'm going to invite two different colleagues to the screen. So our wonderful colleagues, Dr. Sandra Husbands, who is the Director of Public Health for City of London and London Borough of Hackney, who has proactively been helping shape our manifesto, and it's been really valuable. I mean, Sandra and many others, but Sandra is one of the colleagues. And Peter Hay, who is a non-exec director at the Health Creation Alliance, and he said, just introduce me as a social worker. He's actually the chair of Social Worker of the Year Awards and a former president of ADAS. And many more things, but Peter and Sandra, let's bring you into the conversation now and ask you to give us 5 minutes each, Peter on social care and Sandra on public health. Over to you.
Sandra, would you like to go first?
Well, thank you, Peter, although I was expecting you to go first, but happy either way.
All right, shall I kick off then? Cool. We've been talking about books, and I've read one too. Danny Dorling wrote a fantastic book called Shattered Nation, which is actually full of facts and evidence, which is kind of quite good. Like, did you know that we have twice as many food banks as we have McDonald's? But there you go. He also identifies 5 new giants that replace the beverage giants: hunger, precariousness, particularly in housing, with both affordability and staying in housing, waste, exploitation, and fear. And he draws out a lot of the things that indicate that actually the challenges for the next government aren't just fixing the social care system. They're to do with things like housing, university fees, the benefit system, or the fact that child mortality, which used to be a real pride for us in this country, we're now beaten by 22 European nations on. So there's a whole load of things in the new government, in the next government's inbox. But what's really was striking for me is that Danny Dorling places adult social care, which he's got quite a lot to say about, underneath fear. And at first I found that really hard to accept, but actually it'll settled on me that actually we've had a debate which is about how to afford at very expensive amounts for the care system, and also about eligibility, which is about the level of lack of things that you can do before you qualify for a pretty poor service. So perhaps unsurprisingly, people are frightened of it. And actually what I'm going to argue for is that the 3 C's of health creation are actually the underpinning of a really different way of thinking about how social care needs to be there in the future. Firstly, we've got to deal with the first C of confidence. That's critical, I think, to some of these issues of fears. The House of Lords report into the issue was called Gloriously Ordinary Lives. And that's what people are seeking and want the confidence to build. My mother, a great guru in my life, says that actually aging is hard. That actually something about particularly that point where you reach being very old and have experienced multiple losses, both in your own physical ability, but also in your entire network, is quite tough. My mum says it takes energy to be old, but it doesn't have to be this hard. The decisions that we take and the way in which we approach building glorious lives, or perhaps even being really bold and thinking about glorious end of lives, are really important. Second C is about connection, and we all know the dangers of loneliness, I think called a bigger killer than smoking at one point. So something about how we connect to deal with the kind of side effects of the loneliness that many people experience. whether they are in young or old age. But also something about thinking about how we build something greater about resilience. I really like Judith Rodin's work, where she describes resilience not as an individual trait, but as a characteristic that's very much rooted in community. She actually highlights how social cohesion is always the first responder when things go wrong, and that actually in this world of more shock, we need to be better prepared, be able to adapt, be able to respond, and be able to learn and grow more than we've ever done. And Judith's got this great analogy that resilience is like a bank. We need to pay into it when times are good, so that we're drawing off it when times are not so good. And something about how through that connection, we can all help the people and places that we care about, and we can pay into our bank and draw out of our bank. And finally, the last C is about control. As we review the Care Act, we need to think about why is it that the use of personal budgets, which was one of the manifesto commitments and one of the really strong demands behind the Care Act, has actually fallen. We're giving people less control over the resources. Equally, and we'll have more to say about kind of the big complex issues about provision in social care. I'm sitting here in the headquarters of Anchor that provide housing and care to 55,000 older people, and we call ourselves, we redistribute our profit. Every pound of profit we make goes back into the business to build better quality and better standards. In a world of tight resources, particularly in adult social care, why is it that profit isn't always necessarily purposeful and redistributed? Why is it extracted? And we need to ask some serious questions, particularly in mental health and learning disability, about the extent to which that has grown, not as explicit public policy, but hidden out of view, just as sometimes the people themselves are out of view. So something about the accountability of and structure of provision is important in the debate about control. Another book well worth reading is Richard Humphreys and his diagnosis on social care. And he argues really strongly that we don't need more top-down approaches to care reform, but we need a concerted attempt to work outwards and upwards from a community level. That's a health creation approach, if ever I saw one. It doesn't absolve central systems from the right funding and for the right incentives, but it's something about actually how we need to grow this in a very different way, in a devolved set of structures that actually recognise and value the importance of local government and local partners, and see how they can be stimulated and grow from that. Because actually what we need to do is move from approaches that seek to avoid adult social care and living great lives as we grow old or as we live with disabilities, but actually think about how we promote those gloriously ordinary lives. And we need a promotion-based approach. And finally, it's something about recognising the contribution that people make and really valuing and enhancing that based on the recognition of all of our skills and talents. We often think of old age and residential care as kind of being the last stages of life. Actually, one of the examples I've been looking at today is a little project that our residents in a care home in Knaresborough put together after the death of a resident who had really enjoyed reading to young children. And what they've created in her memory is a community library called the Little Library, aimed at young children, that they come in, borrow books, but also have an older person who can sit and read with them, or just sit and enjoy the conversation and the chatter. That community connection by people who still retain skills, talents, or histories are part of what brings about gloriously ordinary lives. And that's what I think a health creating approach to social care reform would really offer. That's probably 5 minutes. So.
Thanks, Peter. What I'm going to do is give a bit of a personal as well as professional reflection on where I see health creation working in public health. And the reason I'm going to do that is to kind of get you to see how I've come to this conclusion. And it is partly because of my training and what I've learned while doing a master's in public health, and from working in Wales, where we had the Future Generations Act, which is also based on the UN Sustainability Goals. All of these are things that we can kind of see echoes of in the health creating approach. But the thing for me is that I started off as a doctor, went to a very traditional old medical school where We learned everything in terms of the medical model and very much focused, for the most part, on hospital medicine. We had a fairly good percentage of people who went into general practice, but public health wasn't something we considered, and sort of community power with patients and their relatives was just never even a consideration. And so that's where I started. But when I look back on it, and I started off thinking, I just really need to understand things. I need to understand how things work. And I went into research and I was asking these questions about really detailed elements of how the mechanism of things are, because I thought that was the way to make things better. But the more I did that, the more I realised that actually you can exhaust all the questions, but nothing changes unless there's a will to change. And I thought at one point that that was about political will, but actually that obviously has a really important role, and particularly where I work in local government, it's very important. But the political will is, to some degree, a manifestation of the community's will. And community will, community power, is absolutely paramount in us being able to achieve anything at all. And I started to learn that when I went into public health, and quite early on went to a conference around social capital for health. Have been fascinated with it ever since. Found it really difficult to get a handle on what does that mean in terms of what I need to do as a public health professional, or what do we do collectively as a group of public health professionals. And partly because of political will and expediency, and partly because of accountability, we've been very much driven in public health down the road of saying that we have to do things about individual risk factors, or I should say individuals' risk factors like smoking and obesity and physical activity. And what we have to do is tackle it individual by individual, which is still very much the sort of medical model of health. It's about an intervention with an individual where we determine what the intervention is and they come along and get a service. And it's kind of driven us into this place where, including in local government in England, where we've been given these budgets and we're told that we have to commission certain services, that there are a number of people that seem to think that that's what we do and that's what we should be doing. But my argument is that that's not what makes people healthier. Doesn't even necessarily give you long-term outcomes for the people who engage with those services. So, for instance, individual behavioural support and nicotine replacement therapy for people who want to stop smoking is a really effective way of getting people to stop smoking. And you get something like, you know, depending on the nature of your service, you can get 70% of people being able to quit. And our measurement for that is, you know, have they stopped smoking for at least 6 weeks, and we can measure that by seeing the reduction in carbon monoxide in their bloodstream. But we also know that about 63% of those people have started smoking again within 12 months. So what's our long-term plan? How are we supporting those individuals, and more importantly, the community around them, to support them to not smoke? And I'm sure you all know about all the different levels at which public health needs to operate. So we've got that sort of policy, sort of national policy and legislation, we've got local policies, but actually the real crux of it is the reason that people are stopping smoking now is that it's become socially acceptable. It's about what the community wants and how the community behaves. And that's why I think that social capital is such an important, health creation is such an important hook for us in public health. If we want to actually get healthier populations, then we need to start thinking in this health creation way, not to exclude the commissioning or provision of individual services, which are really important for people who need behaviour change or treatment, but because if you want to have an overall healthy population, you have to think about it in this way. And that's where the thing about social capital comes in, is that that's about the connections between people, between individuals, but also between communities and between communities and services or sources of power, like, you know, democratically elected representatives. Thinking about just in terms of an example of where a public health intervention can fail to take hold, a really good example of that would be the struggle we had at the beginning, and actually we're having still more generally, with getting people to take up vaccinations. When I said at the beginning, I meant the COVID vaccine. And one of the reasons that people weren't taking up the offer is because they just didn't have the confidence in us that what was being offered was something that they could rely on, or that it was safe. So that's partly about confidence of communities in us, but that's what it works both ways, doesn't it? Did we have the confidence to give them the information that they needed? Did we have sort of a mutually reliable and trustworthy relationship? And then what degree of control did they have? So what we're trying to do now, just to finish on an example of how I'm trying to use this sort of health creation approach in our work locally in City and Hackney, is we're looking at social capital and saying what social capital as a determinant of health is one of the building blocks of health. So the relationships, those formative and mutually beneficial relationships in terms of social capital that can lead to good health, but also lead to those other building blocks that are referred to in our health creation model. And we're going to start by going out to our communities and listening to them and having a dialogue about what's good in their community, what do they want to build on, how do they perceive their health, and what's important to them. And the truth-telling comes in both in terms of us being really clear about what we can and can't do, what's within our scope, what isn't, what resources do we have, and what we can't do, depending on resources or our authority to do it. As well, they can just be as truthful as they want to be with us about the ways in which we've let them down in the past and what we need to be able to do together to move forward. And I'm using the word community really specifically to mean people who live in our area, and how do they define their communities, whether that's by the place that they live or the ethnic or religious group that they belong to or whatever, but also to work with and through community organisations who already know those communities and have the opportunity to sort of introduce us as a trusted partner to work with. And I'm planning a series of community-led health needs assessments. I'm calling them health needs assessments because that's our classic public health jargon. But it will be with a strengths focus. It's not just saying how much diabetes do you have or how many people are obese. It's actually saying, well, what are the needs and the opportunities to improve and create health in this community. And then working with them to support them in whatever way they need to self-organise. And this, of course, is a reciprocal thing. You know, I have a responsibility for the health of my whole population, but I can't possibly go around and treat them all individually. So I just need to work with them, which requires that power shift. And in a nutshell, that's our health creation approach to public health. I did want to name check somebody, but I think she's left. And that's Sandra Omar, who has been fundamental in getting me to understand the value of community development in public health.
Thank you. Yes, Samira is incredible. So shout out to her. As are all of you, I'm seeing a lineup of people here who are doing just incredible work. So thank you to everyone who's here and for all that you do. If we don't manage to say it later. We probably don't have time for questions now, but if it's okay, what I'm going to do is propose that we go to Rachel for your presentation, and then we bring back all our speakers for a quick question and answer, if that's okay. So let's now move on to the next item, which is community-led organisations focused on health outcomes. A 5-minute presentation from Professor Rachel Baker, who is Director of Yunus Centre for Social Business and Health, Glasgow Caledonian University. And just to say again, thank you, Sandra and Peter, for your input, but we're going to bring you back into Q&A after this presentation, if that's okay. So, Rachel, over to you.
Thank you, Durka. And I did bring some slides. I wonder if we could pull those up, please, Neil. Thank you so much for including me in this programme, and I'm learning so much by listening to the discussions and following the links in the chat, so it's really fantastic. I'm here to talk about a research project called Common Health Assets, which is live and happening now, and involves a large team of people. If you could go to the next slide, please. It's an exciting and ambitious 3-year research project funded by the NIHR. And we're looking at community-led organisations. So by that, we mean place-based organisations who are governed by and owned by communities, and trying to understand and evidence their impact on the health and well-being of people lived in what are often called deprived or disadvantaged areas, but by which we mean areas that are not doing well by any measure of indices of multiple deprivation, and really at the wrong end of what we know about health inequalities. These organisations are doing lots and lots of different things, so that they look different in some ways, but they're bound together by a common way of doing things, which is sometimes called an assets-based approach, and echoes very much some of the words that Dusty was using earlier around working with people and not doing to them. So, and the way that we're trying to do this research is very much in the spirit of that. If you could go to the next slide, please. We're asking, do community organisations impact on health and wellbeing in disadvantaged areas? And if so, by what mechanisms and in what contexts are those outcomes achieved? Those of you who are interested in research might recognise this as a very realist way of framing our questions. So we're not saying, does it work? What does it cost? We're asking what works, for whom, in what circumstances, and how. And we're adding to that some research into the economics, sustainability and scalability of CLOs, as we're calling them, community-led organisations, and their activities. Next slide, please. The Common Health Assets team is fantastic, and it's big, and I don't have time to credit all of the fantastic people in that team. But I think it's worth saying, and it's important in this context to say, that it's an interdisciplinary team, not only in academic university terms, but also because we have community leaders, community development experts, people who are leading networks such as the Health Creation Alliance or the Community Health Exchange involved as part of the research team. Next slide, please. So that's the very beautiful team, alongside which are lots of logos of the community-led organisations that we're working with in Scotland, England, and in Northern Ireland. We're working with 14 community organisations, and through those organisations with over 350 participants. Next slide, please. Also important for me and for the quality of our research, the appropriateness of our research, is that throughout the work, the 3 years of the research project, in parallel and working with a lived experience panel. So these are 12 members of communities in Scotland, England, and Northern Ireland that come together regularly and keep in touch throughout the research process to advise, to help us interpret, to help us to conduct our research in the best possible ways. Next slide, please. So this is a picture of the study. This is what we're doing and what it looks like. And I am not going to be able to go through every element of this in detail in the 5 minutes that I have, but I'll summarise it, talking about it in 2 phases, phase 1 and phase 2. And I would encourage anybody who's interested in the work to go to our website, where you can see more on all of these pieces. In phase 1 of the project, we are drawing on knowledge we already have and pulling it together to come up with theories that explain how community organisations impact on health and wellbeing. So that comes from the literature, previous research, policy, but also from the knowledge that's held in the brains of our stakeholders, people doing things that they know work in particular ways on the ground. At the end of phase 1, we had a number of theories, and in phase 2, we're setting about testing those theories with new data. So a longitudinal questionnaire study, an economic evaluation, some Q methodology work, and so on. And we're right in the midst of that work at the moment. On the right-hand side in the orange boxes, you can see all the different ways that we're trying to engage in knowledge exchange while we're working on the research, and also the dissemination, not just through academic papers, but through social media, through videos, through photography, and so on. Every circle on the screen is a different subcomponent of work, and some of the challenges is in bringing together that multi-site, multi-method approach to research. Next slide, please. It's very risky to present findings while you're still testing them, but I wanted you to see what one of the theories would look like. So we've got 10 different theories that we're testing, and they will fall away, strengthen up, be revised and refined through the work that we're doing. This is just the first one, so I've just pulled it up to show you. And what this is suggesting is that, and consistent with lots of the health creation messages that we've already heard, that control and choice and being involved in decision making might be seen to lead to health and well-being through pathways that involve a sense of self-worth, empowerment and confidence. So this is not a final theory, this is a working theory that comes from existing knowledge which we're testing and which we will refine. Next slide, please. So just to give you a sense of watch this space and where we are, where we're going with this next, we'll be putting out and testing out our interpretations and findings in all sorts of different forums as we're analysing through the remainder of 2024 and into 2025. So I'd encourage you, please get in touch with me if you're interested in following up and finding out more. I'm happy to share my contact details. But next slide, please. I'll leave you with our website and our Twitter address so that you can follow and find out more. This has really been a whistle-stop, I think, tour of what we're doing, and hopefully just to give it some profile and benefit from your input and expertise. Thank you.
Thank you. Thank you very much. And what a brilliant example of partnership working. It was just to see all the logos there and all the people. Isn't that amazing? So now what I'm going to do, so we haven't got long, and I do want to make sure we've got enough time for Lord Nigel Crisp as well. But it's just to bring in colleagues, and especially I'm going to invite, so Rachel, Sandra, Peter, Chris, Merron, and then if you're willing, kind of, we've already worked with Lynne, Dusty and Donna quite hard, but if you're going to join us as well, do. And Merron, I'm going to invite you into it, so we can't let you hide. So bringing you into this one as well. But basically, not loads and loads of questions in the chat. I think there's been a huge amount shared, both by speakers and on the chat. So a huge resource for people to look into and keep using. But the one question, just to whiz around from you all, if that's okay. Same question to you all. What is the one thing that you would like now to see happen in terms of the manifesto to make health creation happen in practice? Shall we go in the order I've got you there? So Rachel, Peter, Donna, Sandra, Merron, Chris. So just to get one comment from you, and just to be able to thank you for all your inputs. So Rachel.
Thanks, Durka. Gosh, on the spot. I suppose because my head is so firmly in the community sector and following lots of what everybody else has said, I think I'd like to see both the funding and the integration of that part of our economy and society much more baked into what we're doing in terms of health and health inequalities. So I'm going to be really quick, and I'm going to make that my one plea.
Amazing, thank you. Peter.
A real acknowledgement that we're in uncharted territory in a society that has more people of older age than of working age, and that requires a fundamentally different approach, because no matter how many obscure rocks or Rosetta Stones we look under, we won't find the workforce of our current models, and we need something fundamentally different.
Wow, thank you. Donna.
It's a bit hard to follow that one. I think what I would say is we need to trust each other and just hold hands and maybe carry on with Peter's analogy and kind of jump into the unknown together. So there is something for me about finding your tribe, developing that trust, and being brave and doing this stuff. Thank
you. Sandra.
I'd like to see people stop talking about and thinking about prevention as we've prevented people from coming to use our service, and start thinking about improving people's lives, improving people's health. And so that will include some prevention of disease and some prevention of accidents or whatever that might drive people into services. But what we're trying to, the fundamental point is that this is about improving people's lives and creating health. And so whatever needs to happen to get that way of thinking inculcated in people is what we need to do. If I can get a cheeky second one just following on from Rachel, some flexibility about the way we're allowed to use the money would really make a difference.
Thank you. And I know we had a few sound issues with your mic, so if there's anything people can't hear, we can always, oh yes. So Neil's put something in the chat, just saying that we've got captions as well. Great. Merron, let's come to you.
Thanks. Yeah, I think that as for professionals, I think professionals need to stop looking up as much as they do to hear what needs to be done and start to push back on some of it collectively. And look sort of down at where the health creating stuff is happening, because we should be able to spot it now. The framework, if you get your eye in with that, helps you to spot health creation that's happening. And then how can you get behind that? And those people that are doing it, ask them how you can build that, make more of it and spread it. And actually there's a sort of, by looking up, I think we're being pushed apart too much by having to do certain things. Whereas if we connect together and build coherence around a different story, that can be quite powerful in getting change. So look outwards and downwards and get behind the health creating stuff that's happening often in the community.
And Merron, a cheeky second one for you, if that's all right, which is absolutely agreed. And I guess some people sometimes, I mean, it's easy to say, but sometimes people need a helping hand to actually do it in practice. And things like our discovery learning programs have actually, people have found it to be really helpful. So I don't know if you wanted to say just a word about those as well, to save me from adding it to the end of the meeting. Sure.
So we've learned how to apply some of this in lots of different settings, and actually the discovery learning program is an example. There's a number of elements to it, but we can pick and mix depending on where systems and places and neighbourhoods are already at and what needs to happen next. So we're quite inventive, and we can help people across systems to sort of break through on some of the difficulties they're having. We can often spot where things are going wrong and help that breakthrough. So do come and talk to us if you want us to help you at all.
Absolutely, thank you. Last but not least, but for this bit, before we hand over to Lord Crisp, which is I wanted to come back to you, Chris, because you so powerfully started us off in the beginning. To now going through that journey and back to you, what are your thoughts? What's that one thing that you'd want us to do?
I mean, I hope, sorry, excuse me, I hope that perhaps today and the manifesto going forward can be the catalyst that actually makes the NHS stop thinking about this stuff as nice to do. Because 10% of every NHS budget is supposed to be used towards reducing health inequalities, but that's not quantified or measured in any way at all. And I think that's partly because we've never had a proper framework to do so. So if this can become the mechanism for actually reducing health inequalities, there should be money there and it should be ring-fenced. So I hope that's what happens.
Thank you. And maybe that's not just a message for the NHS, maybe that's for each and every one of us, maybe not just about money, but personal commitment and then translating it into action, as Bola rightly challenged us to do. Amazing. Thank you. Thank you to you all for your excellent inputs, and to colleagues on the board for being just so fab to work with, and others who are behind the scenes supporting. We'll love you and let you go back into the audience now, and instead invite our final speaker. We've got Lord Nigel Crisp, who is crossbench member of the House of Lords, where he co-chairs the all-party parliamentary group on global health, and is a powerful advocate for so many things relating to this, but not least the international learning in practice and the cross-fertilization of ideas. So he's going to talk to us for 10 minutes about, can health creation really become business as usual? A loaded question. Lord Crisp.
Well, firstly, Nigel, please. The title may get you into the room, but once we're in there, I hope we're all using first names. Great to be here. Great conference. Great manifesto that you've delivered as well. And I congratulate you, Durka and Merron, for everything you're doing and how you've moved this organisation on. I think it's a very sophisticated manifesto, and I wish it every success. Just a couple of comments on some of the things I've heard. I just want to point out three things and then put in a little bit of sort of slightly fresh input. Firstly, I was, of course, very struck, as obviously you were, Durka, by Chris Carlin's comments and the translation between him being a local man and him being a professional. Well, it rang a bell with me partly, Chris, because you won't know this, but I was actually a community worker in Halewood in Liverpool in the 1970s for a few years, and then a few years later on, I ended up running the NHS. So maybe that's your next step in life, Chris, as you move on. And I understand that problem of translation. But one of the things you said and made it very clear was it's actually about people. You know, there's a lot of talk about structures and policy. This is about people. And a lot of other people have made the point that it's about relationships, haven't they? And then I think it was you, Donna, at the end talking about trust. So, you know, three big things I take out of what people have been talking about are: this is about people, this is about relationships, this is about trust. Now, the task you asked me, you set me, Merron, was to say, can it be business as usual? Can it be core business? Can we move from words and wonderful policies actually into some action, but actually not just into some action, into sustained core business, business as usual action? And the answer to that, in my view, is that this is all about the professionals. But it's all about the professionals. If the thoughts and ideas you have got are inside the heads of the health visitors, the GPs, the community nurses, the paediatricians, they're terribly important in this, dealing with families as well, psychiatrists, I guess, the physicians, indeed, the whole range, as well as, of course, public health and the sort of range of jobs we've seen represented here. And if that doesn't happen, it won't happen, unless this is core business for the core members of the NHS and social workers too, forgive me for not saying that. If it's not core business for them, it won't be core business. Politicians can do what they like, and do bear in mind, if I'm slightly cynical, but most policies don't get implemented. You do know that. And most policies don't get implemented in the way that the authors of them thought they should be. So one just has to be, you know, policy is frightfully useful or can be very destructive, but actually what gets stuff done is people and relationships. And I think all the things that, and I've also done some research around, in fact, in that book that Chris referred to, around the health creators in our communities, and it's people and relationships that they start with, and vision and passion and energy and momentum, all those sort of things. So I think the big lever that we need to pull, and you can't do it directly, but I think there are aspects in which you can help, is actually about the professional education. Now I'm working with a group we're going to launch in July called Hope for the Future, which is a group of young professionals and students who are wanting to change professional education so that it starts to focus on all this sort of stuff. And I think there are links you can make as an organisation with the nursing schools. You know, nurses are fantastically important. You know, the medical schools, the physiotherapy schools, all the sort of people who are actually going to, you know, actually who for whom it has to be core business. Because as I say, if it's not core business for them, it won't be core business. Because it won't get done. Because what will happen is once the pressure comes on, and my goodness, the pressure is on, you'll revert to your old way of thinking. And if your old way of thinking is biomedical and money, then you'll be biomedical and money. You won't be biopsychosocial environmental, which is the sort of direction that you are all pointing in. So I think there's some really important bits there. We did a study on this from that all-party parliamentary group, which, by the way, no longer exists. We've stood it down after 10 years, which was looking at the future of health professional education. And the great title is Probable Futures and Radical Possibilities. And we saw within that as AI gets stronger, as technology gets stronger, as management gets stronger, where's the space for the professionals? And one of the spaces for the professionals is to be what we called agents of change and curators of knowledge. Just the sort of people you need in these communities, the sort of professionals. When I was a community worker in the 1970s, we used to talk about non-directive leadership. It's the same thing. It's actually the bit that Heather Henry talks about when she says you start at the front of the room and you move to the back of the room over time when you're working with people in the community. So agents of change and curators of knowledge, I think that's a really valuable role, and it's what this group of young professionals are working towards, to recognise that in 20 years' time, health professionals are doing will be very different. But you know, but they'll still have a major role because they will be helping with non-directive leadership, if you like, to shift people on. So the other thing you asked me, so that's the one thing that I would add to our discussion, is the importance of that. You've got the great policies, you've got great people, you've got great examples, you've built up this network and so on, but we need to shift what's happening in the education circles in order to shift this on properly, because this is mindsets, isn't it? Relationships, people, and trust. You asked me as well, Merron, just to say, how would I advise people to help make it core business? Well, how people would be thinking about in the future. I'm just going to throw in 3 quick things. The first one, actually just start acting as agents of change and curators of knowledge. And that's actually what most people here do. I think that's, don't know what Chris thinks, but I think that's the sort of thing you're doing. I think that's what you're doing, Dusty, from what I could see of it and what others are doing. And there are many examples of people doing that in their own individual way, but not because it's core business. So agents of change and curators of knowledge. Curators of knowledge because actually you're not telling people the answers, you're helping them to find them. And you're helping them to say, look, there is this bit of research or whatever. The second thing is sort out who your allies are. Who are the allies in your area? And let me give you one ally that I think may be really quite relevant. I'm co-chair of another APPG, which still exists, called the APPG Beyond Pills. Can you imagine what it's about? It's about the fact that in the last year, 2022, 2023, a quarter of adults in the UK were prescribed a psychiatric drug. And in that same period, 4.5 million under 25s were prescribed an antidepressant. And we have just launched a report on Tuesday called Shifting the Balance Towards Social Interventions and Away from the Biomedical Model, because there's so much more can be done. And you will know in your community, so in any of these communities, there are huge numbers of people with these with problems. And one of the problems is when you're on an antidepressant, you may have very great difficulty getting off it. And there's not much support around that at the moment, which is also what what our program is about. And Merron, if I may, I'll send you a link to the report if people would like to see that. But you know, so find your allies, people like that. And then my third point, and I think Peter was just making it somewhere along the line about, actually there's lots of people here that life is changing. We don't know the answers. We're in this massive transition. We can see some of the pointers. We know the broad direction we're going, but we know the vision, I suppose, in some ways, and we need to shift around. And one of the things we must do is a great North American saying, which is waste no will. Sometimes when people are on these journeys, they fix on something that they think is the right thing to do and suggest everyone should do it. And if you're not doing it, you're not doing it right. And what this I picked up in North America in Harvard actually, was this idea that if somebody comes to you and says, yeah, but you know, what you should be doing is X, you don't say, no, we're going to do what we're doing. You say to them, well, let's talk about that. And you talk about it. Maybe you change what you're doing. Maybe they change what they're doing. But you keep the energy and the momentum going together. And what this needs is energy and momentum now more than ever because of the deeply problematic climate that health and social care workers, maybe social care workers in some ways worse than health, are facing at the moment is deeply problematic. and the landscape is changing and so on. It's major problems. And within all that, you need the energy and the momentum, and you need people working in the same direction. So my 3 bits of sort of more or less personal advice are: act as agents of change and curators of knowledge. See where you can make a difference in that sort of way. Secondly, find those allies, and they may be people like us dealing with over prescribing, over medicalization of the agenda, and waste no will. You know, pull people towards you, go towards them, keep working together in a world that is uncertain, but we'll get much more certain eventually. Don't know when, but we'll suddenly discover we have got a new norm. We'll suddenly discover there is something that's business as usual, and it isn't the old biomedical model. And worth bearing in mind, the biomedical model in psychiatry only arrived in the 1980s. That's only when we really started drugging everybody up. So, you know, it does change, and that cycle, I hope, is coming to the end. But I just use that as an example of what we need to do. So people, relationships, trust, waste no will. Thank you very much.
Thank you, Nigel. Goodness, powerful words, simple messages. Again, a lot of appreciation in the chat in terms of just how helpful that is in terms of landing our very important discussions from today. So there you have it. We've reached the end of our spring event, but it just feels like the start, doesn't it, of a new chapter for the Health Creation Alliance in terms of the work that we are doing with you, and also for all of us in terms of delivering on the manifesto that was launched today. So a big thank you to our speakers, so to Chris and Mark, Bola, Lynne, Dusty, Donna, Sandra, Peter, Rachel, Nigel, and of course to Merron, Neil and Lee, and to each and every one of you for joining today, for watching the recording if you're doing so afterwards, for everyone who's contributed in our work to date in all the ways that you have. It is so valued. Do get in touch if you want to find out more about our Discovery Learning programme. Do also join the movement for health creation. It's free, and there'll be links in the chat or in the email to opt out if you wish. Do stay in touch because it's by together and keeping on going that we will actually be able to take this further in the way that is possible. And please keep doing what you do because it is so valued. So thank you from me and the team for today, and no doubt see you again soon. Take care. Bye.